Good morning, everybody. On behalf of Dr. Dempsey, who couldn't be here, but I'm sure will be looking at the video, and the FIENS Foundation, I'd like to remind everybody of what this visiting professor sessions do. And they really, not only do they give us tremendous amount of information from up-to-date and really well-known and acclaimed neurosurgeons, but they also connect us with our graduates from the FIENS fellowships. And I think that that's probably one of the most significant parts so that we keep in touch with the FIENS fellows as they go out into their practices. The number of FIENS fellowships is really increasing. There are a number for residents, there are a number for younger neurosurgeons in practice. And so that's a major part of the FIENS organization's mission. Today, we're really fortunate. Oh, I want to mention one thing before we go any further, and that's that Jeannie Bray has been a major part of really keeping this visiting professorship on track because we connect with the folks that are going to speak to us, but Jeannie is the one who does all the arrangements. So thank you, Jeannie. Today, we're really honored to have Dr. Jesús LaFuente from Barcelona. He's going to be introduced by Dr. Alfin, and Dr. Alfin, for those who don't know, did his Bassett Fellowship, I think it was about a year ago, at the Barrow Neurologic Institute. He's currently in practice as a neurosurgeon at Jos, I'm probably pronouncing that wrong. I'm sorry about that, Dr. Alfin. University Teaching Hospital in Plateau, Nigeria. And with that, I'll turn it over to Dr. Alfin, who can introduce Dr. LaFuente.
Okay. Thank you, Jack, for that wonderful introduction. And thank you, FIENS, again, for giving me the opportunity to moderate this visiting professorship webinar. It's a great honor to be talking about minimally invasive spine surgery, the future of spine surgery. So it's an honor for me to introduce our guest professor and speaker today, who is Dr. Jesús LaFuente. Dr. Jesús LaFuente is a consultant neurosurgeon at the Hospital Universitario del Mar in Barcelona. He's also the director of spine unit. And Dr. LaFuente will be presenting minimally invasive spine, the future of spine surgery, exploring the innovations that are quite transforming patients' outcome and expanding the access to advanced care. He has been a global leader in neurosurgery education. He is the past president of EANS. He brings extensive experience in both academic leadership and international outreach. And please, without much ado, I want us to welcome Dr. Jesús LaFuente to take the stage and have his presentation. Thank you, Jesús. You're welcome.
Thank you, Dumura, and thank you, Jack. Thank you, Jean, and thank you, everybody. And particularly, I don't know if she will be there, but I hope Gail Rousseau is there because she was the one to push me to give this talk. I've been following FIENS because of her many times, and she has been a very big advocate to FIENS and all the activities they do. And I feel very proud to be and honored to be here today. I'm going to share my screen and I'm going to talk, as Dr. Alfin was saying, about my experience and my views about what minimal spine surgery means, a specialty that I took on fairly recently, about 15 years ago. I've been 25 years as a neurosurgeon, but this came out maybe a bit earlier than that. But I was involved with Rick Fessler and Roger Hartle, and from then on, I've been very much involved with minimal invasive. So for me, it's a change in the paradigm and definitely the future in spine surgery, and I will try to explain how and why. I have a few conflict of interest to be declared. I have consultancies from two companies, and I am also a shareholder of one of the robot making. I am involved with that. And this is all technology related directly with minimal spine surgery. Now, we all know what the spine is there for, and it's got a huge biomechanical balance function. This is key for allow us to walk into with by pedestation, but also has other basic functions like the motion, as I mentioned, but also to protect the neural structures, the spinal cord and the nerves, and give us support to the body. This gives us a cone of economy where the muscles, together with the ligaments and the bones, act in harmony to allow us movements without any pain and so on. This is the reason why minimal invasive will help us to prevail and prevail this structure that we all should embrace. As surgeons, we have to embrace different surgical approaches, the new technology, a highly demanding society which expect from us every time more and minimal complication rates. We need to adapt to social media, which can be regarded as good and in many occasions as a bad. And sometimes, particularly for me, when you are advancing your medical career, to embrace new technology which requires some form of a learning curve is difficult. But if you do it for the sake of patients, I think is worth it. The beliefs about minimal invasive surgery is that it's supposed to be better for the reasons that I explained. Is a modern technology, which we all think that modern is great. Not always is the case, but in this occasion, I believe it is. And it's cutting edge technology for skilled surgeons only, which I do not agree with that, but this is the perception many people has. And of course, in order to perform minimal invasive surgery, you are required to have the technology and guidance available for it. Of course, minimal invasive, with all the limitations that they have, you have to compromise on the level of the compression that you will achieve. You have to compromise of the strength of the construct that you will also achieve. You have to compromise on how the bone fusion can be applied or can be helped towards this fusion. And also, when you do tumors through minimal invasive approaches, you need to compromise on the exposure of this tumor removal. This is Rick Fessler, one of the fathers of minimal invasive surgery, and you can see the graphs of when he started doing this. In 1992, there was no minimal invasive surgery. There was a cervical discectomy, which I think it is considered minimal invasive surgery to the cervical spine, but at the lumbar or the thoracolumbar region, there was nothing like it. And slowly little by little, slowly, counting on the demands that require, which would create the technology that would allow you to introduce minimally invasive techniques. He has been working out, and you can see in black the graph of things that have gone from non-minimally invasive to minimally invasive procedures. Up to 2010, I believe we had covered 90% of all spine surgery through minimally invasive procedures. And Rick Fessel has been a key element on this. Of course, he has done all the papers, as you can see, and he has demonstrated that through minimal invasive procedures, there's less pain and pain medical requirements, there's less blood loss, there's lower infection rates, there's less ICU time spent by the patient, therefore less hospitalization as well. Less psychological stress, and this is very important, we'll point this out later. Fewer complications, less muscle atrophy, and equivalent decompression of neural elements if you do it the way you have to do it. And you preserve normal motions, and in many occasions, you will not have to do arthrodesis. So advantages and disadvantages, as I mentioned on disadvantages, learning curve can be steep, particularly when you have no experience on this. Operating without anatomical visualization always is a limit, because if you're used to know your anatomy through a little tube, anatomy landmarks are not very clear, and sometimes you can get lost. And radiation. This has been one of the biggest arguments against it. With regards to the advantages, we all know the advantages. It preserves muscle, ligament, and bone structures, which also prevents delayed instability. And this is one of the key questions in spine surgery: avoid creating iatrogenic instability. You can see here In a patient on the top, which is an open an open laminectomy, a mini laminectomy, you can see the muscle structures in that area, which they are fibrosed. And if you see in the lower X-ray, you can see the preservation on the left side of the muscle structures with a little bit of fat, which is pre-op, and you can see exactly the same pattern after the decompression has been achieved. So muscle preservation is clearly demonstrated on minimally invasive surgery, which will be of benefit for the patient in the future. One of the big things on spine surgery, and one of the things we like to do with synovial cysts. Synovial cysts are, by definition, an indication of spine instability. And traditionally, these procedures have involved a 360 construct with removal of the cyst. It's an unstable lesion. You can see some of the cases here, the misalignment of the vertebral body, how this is looked through the microscope, and this is how they normally ended up. This is an X-ray about 20 years ago. We put some screws with an expandable cage, remove the cyst, patient happy, but look at the incision, look at the muscle damage or the muscle atrophy created through this operation. Can we do this any better? And certainly, I believe we can. And we should be, if the cyst is in, as you can see in this round orange circle, you can approach that way. If you want to do it unilaterally, the problem with unilateral approaches is sometimes you cannot distinguish very well the plane between the dura mater and the cyst, and this can lead you to unfortunate CSF leak or opening of the dura inadvertently. Now we use to do this contralaterally. What is the advantage of doing it contralaterally? You preserve your side facet joint perfectly well, the ipsilateral one, and you go to the damaged one contralaterally, and you can do very little damage to the facet joint. You will find the plane between the cyst and the dura mater easier, and then you will exactly know where the cyst is. Therefore, you can remove it safely without causing any damage into the dura or to the nerve root exiting. How about disadvantages? Well, the learning curve is steep, but now we're teaching these procedures to all our residents from year one. What we also teach them is in open surgeries where the anatomical landmarks, the TPs, transverse process, the facet joints, and so forth, and these are the structures that sometimes you cannot see visually, but you can feel using a little hook or something, a small instrument through the microscope. How about visualization? Of course, you don't have visualization through a tube, but you must be aware that if things are not working the way you expect, some problem may be surrounding the operation. Don't get obsessed through the procedure. Look around it, and if sometimes you need to expand the procedure, you do that. Don't feel ashamed of having to expand the procedure if you cannot see properly. And about the radiation, there's been lots of studies looking about how much radiation or difference between radiation in an open versus a percutaneous procedure, because of course radiation is a hazard it's a hazard for the patient and also for the surgeon. And there's been a lot of studies looking at this. All the studies show that it's three times 0.2 higher the radiation through minimally invasive procedures if you compare to open procedures. But this is not enough to create a occupational hazard, because as this paper, which won the Young Investigation Award winner, you need about 2,700 TLIFs procedures to perform annually before you exceed the occupational limits. And I don't know you guys, but certainly I do about 250 or 300 surgeries of this type every year. And a nice tip, if you cannot x-ray the patient, minimal invasive surgery is the right patient, is the right procedure for this patient. You don't have to use small tubes as you use for normal weight patients, but in obese patients, you don't have to be scared to use bigger tubes, maybe 26, even 28, if you think you're going to do it comfortably. You don't want to struggle, and the depth can be up to 10 to 15 centimeters below. So have a space with a tube which contains all the fat and all the muscle structures outside the tube, and this makes your life much easier. Of course, one of the arguments, particularly from the managers of the hospital, well, why do we have to buy tubes? Why do we have to buy microscopes? Why do we have to buy this and that to perform minimally invasive surgery? And this is quite a very good study showing that demonstrate cost savings in favor of mixed fusion, ranging from up to 25 up to 49 plus 3% discounts on doing this through minimal invasive procedure. They take into account, of course, hospitalization, medication requirement, and everything. And this is much cheaper than an open procedure. Not only is beneficial for the patient, is good for the surgeon to have and gain skills through small tubes and small spaces, but also economically is good and sound. So, as I mentioned before, you cannot do certain procedures in minimally invasive surgery if you cannot have the technology available. Okay, for a lumbar laminectomy, you just need a microscope. But if you want to go step forwards, you need other means of technological advances. And navigation will allow you to use correct position pedicle screws. And of course, when we talk about putting correct position pedicle screws, we are not concerned of damaging neurologically the patient, which of course is the biggest complication. However, this doesn't happen very often. The problem is that a misplaced or an let's say, not ideal or perfect screw position will wrest biomechanical strength to any construct that you can do, and therefore this can lead to future complications in the short, middle, and long term. These are how you use a tomography-based navigation to locate your screws, and you can see that even 10% you have medial thoracic breach. As you know, the thoracic pedicles are much smaller. You need to use from 4.5 to 5.5 millimeter diameter screws, and sometimes you can breach medially. If you reach only 1 or 2 millimeters medially, if the pedicle doesn't allow you to put a bigger screw, therefore it normally doesn't, it's not a big problem. But if this is more severe than that, then you can have not only neurological damage permanent to the spinal cord with paraplegia or paraparesis, but you can also have other complications like lack of strength of your construct. But we have available for, I mean, not everyone has got the monies to have this high technological 3D real-time image acquisition robots or CT intraoperative CT scans. But there are other systems that can be very, very helpful. And as soon as you can place the screws within a very good range within the pedicle, the action of that will be ideal for the patient. This is, of course, IRO, 3D intraoperative image acquisition with navigation. And this is some of the pictures that we have in our theater. And you can see how the screws are placed perfectly well on very thin pedicle screws of about 4 or 5 millimeters diameter. Of course, the aero not only allows you to do this lumbar spine or thoracolumbar, you can now expand to cervical spine, and this gives you an extra benefit. So you can now treat from top to bottom of the spine using the highest possible precision. This is a study from Roger Hartle, one of our leaders also in spine surgery. And you can see that, of course, you have up to 9% of misplacement of the screws, but luckily none of them with neurological deficit. But I'd like to emphasize that the ideal position is through the screw, occupying all the pedicle screw, as this gives you the biomechanical strength required to allow fusion and to maintain dynamic stability of the spine. Some of the pictures, and this is how we started using simple navigation. This is our 25 years old images in Hospital del Mar. And this is now how we use it with the aero technology, how to introduce the cage. This always gives you a little bit of an edge because you don't see very much. And of course, the nerve root is on the way. But as soon as you are very familiar with the cambium triangle, as you can see here, where the limits are the exit and nerve root, the ligamentum flavum or the dura, medially or inferiorly, the upper side of the vertebral plate. This is the triangle of Cambin, where you have to introduce the cage. Of course, the dangerous area there is the nerve root. You don't want to push it or to press it and cause a deficit there, but you have to be very careful. And now with this new technology, Cambin triangle becomes easier to identify. Many people have been using or trying to find technological advantages to solve one of the biggest problems that we have, particularly in obese ladies, which is sacroiliac ilitis. And sometimes this pain is tremendous and the patients cannot do a normal life. And after you run through several infiltrations and you see they get better, you think that if you fuse this sacroiliac joint, the patient will be better. It's a very clever instrumentation. You can do this through 3D image intraoperatively, and through little small holes you can put and position 3 screws, as you can see here. Unfortunately, I'm not very happy with the system, as I have had a variety of results, some of them good, some of them not as good. Therefore, I don't do this anymore. I'd rather have the patient with infiltrations for a longer period of time, unless she has some lumbar or lower lumbar problems where we can do a short lower lumbar iliac screw fixation. Of course, you can also do this to put lateral screws through a lateral leaf fusion, and you can do this through, again, having the possibility of 3D intraoperative imaging, and you can see how this is very clever. And now we go to the robotics. Robotics is the next step. Robotics are expensive, and the only thing they can be providing now is precision for screw placement. And you can see this robot functioning in the 3 ways, how we use the drill, and the precision is amazing, is very, very good indeed. However, many people will argue that no money will be spent on a machine that can be they can do with percutaneous screws through normal navigation or even X-rays. It's difficult to justify. However, robotics has a future on itself, and it's not only because placing screws, but I think it's more in planning a curve on the spinal, on the vertebral column, from long scoliosis to short constructs, and you will be able to design these with IA, and they will give you how you can bend the rod, what osteotomies you will be able to do, and even the robot will be able to do and perform these osteotomies for you if they are particularly pontes and, I mean, lamina from the pedicle backwards. Other issues are other ways of using minimal invasive, and these are courtesy of my friend John Duff in Abu Dhabi. We all know how important is craniocervical conjunction, and how the craniocervical conjunction depends very much on the well functioning of all the mini muscles and ligaments that they are joining the head to the upper cervical spine. Therefore, when we do a C1, C2, remember that C1, C2 is possibly the more unstable pair of joint of vertebrae in the body, and sometimes for many diseases that you all know require positioning on screws on C1 lateral mass and C2 pedicle screws. We all know that how the relation of the vertebral artery on the C2 and C1 is, which makes this a bit more difficult. Therefore, precision is very, very much mandatory up in the region of the cervical spine and the lumbar spine. And therefore, if you can do this through minimal invasive surgery, this will preserve the functioning of the muscles, which will act as a stabilizers of the joint, together with the stability that you will give them with the screws. If you do an open procedure, you need to make sure a fusion is also with this construct, because if you do not fuse with bone or in other means, this may, as being a mobile area, this may fail the construct. So preservation of the musculature is ideal. And then I will show you how he does this. You need 3 incisions. To do this, perform this procedure, you need real-time 3D image acquisition in theater. You can see the 3 incisions on the patient. The middle one is for the arrow, of course, and the 2 incisions are made to find up, as you can see here. Fusion is very important. Only if you do lateral incisions, you will access the C1, C2 joint, which you will drill and you will fill it with bone. This is the only way where you will fill in bone there and allow further fusion, therefore impeding the failure of this construct. This is how we put a big tube, and then you put C1 through a drill and C2 through a drill. This is through 3D imaging intensifier, and this is how we do this. We perform this procedure very elegantly. Now, how much can we improve? Well, corpectomies are typically and traditionally big operations, particularly after the Patchell paper, where he says in 2005 that it's been demonstrated that surgery will improve the outcome in patients with disease in the vertebral body due to metastatic tumor. These we have been used, me, of course, during my training in the UK, we used to do big corpectomies, and that was a very big and, a nasty operation, as the patient had problems with the lumbar, chest drains and so forth. Now we can do this in a better way through a minimal invasive approach. This is what we used to do on those days. Very aggressive operations, very mutilating and very muscle destroying operations. Now we can see patients like these that they become paralyzed with multi-level disease. We put them on we do a mini thoracotomy, as you can see. We put our special retractors, and this is where technology again help us out with intra lumina light, which allow us to see even better. And we can put a cage, remove the body through that approach, and then go through a percutaneous screws with cement or vertebroplasties to the levels above to give some consistency to that bony structure, which it will not, if you do not treat even with cement. Those contained within the body will make the body to collapse, and then it will be another disaster for the patient. But you can see this is finally with the little incisions in the back and a thoracotomy, and the patient had this done. So this is by Mr. Heisey in Texas Back Institute, and he looked at this patient, looking at, if you do in January, you see this, you see, well, we can wait and see. But if you wait a couple of months, then you end up like in May 2003, and then you can see this is a bigger problem for the patient. So we need to be, before getting to there, we need to be cautious, and we need to treat those problems before they become as nasty as in 3 or 4 months later. So you can see again, technological advantages in the way of retractors, giving you a beautiful view. You can put light down there, and then through a little incision like this, You can put the cage and two screws on the back percutaneously, and this is as good as you can get it. But there are other means now to do and to treat vertebral metastases. You can use vertebral augmentation, as I mentioned to you before, and this is a very easy procedure, very safe, and with little problem. Doesn't give you tumor control, but prevents further fractures, as we saw in the hazy pictures, and this is by itself an advantage for the patient. Also, we can use instruments to give you and to provide bigger or increase the height of the vertebral body, and particularly when you have had a collapsed metastatic injury, as you can see in the picture on the side, and you can see how we place these devices, which you can then fill them with cement in a very safe way, preventing leakage of this cement through the venous system and so on, because this device creates a cavity within it where you can place the cement without major pressure to be insulated. This is other patient that you can plan this through the CT scan, and you can do this and pre-plan it, which is ideal if you can. Of course, you can also use this for osteoblastoma, osteomyelitis, eosinophilic granuloma, and in these cases, some metastatic which are within the body, you can use a thermal ablation of the tumors. And this has been very good. Sorry, this is a complication of one of the devices I show you. I had to remove. So these devices, although very elegant, sometimes also can give you trouble, and this can cause a big radiculopathy on the patient that require to us to find it and to remove it. And going back to the thermal ablation, this is how we use it very elegantly, and I've been involved with this through Dr. Jenkins. He's a guy who works he's a radiologist in Missouri, who was one of the fathers of this treatment. And certainly for all these metastases who are embedded in the bone, is a very good option, as you can control the tumor with the ablation and you can follow through with cementation, which gives you the stability. With this treatment, which is highly minimally invasive, you not only control the bony metastases, but also provide stability to that bone. So you know you've killed or you have controlled that bone tumor and also have reduced the instability of it by doing those two procedures in a whole. You can do this in the sacral bone as well. And also another option is the cryoablation. This is to give you, you freeze tissues at -20, and you follow by a slow defreezing procedure, and this provokes thermal shock, which produces cell death. It's another way of controlling tumors, and there are tumors in the body that act better for cryoablation compared to thermoablation. This is also a minimal invasive procedure, and this is how we use it with CO2. You can see that the cryoablation has happened. As you can see, air within the canal. This is not dangerous, but in a painful osteoblastic lesion, cryoablation seems to work better than thermal ablation or even ultrasound ablation, which is also the third modality of these minimal invasive procedures. So after we did all this and we have been practicing and doing minimal invasive surgery, as Gail knows very much, I have done some surgical missions around Africa, and I thought this could be a very good opportunity to implement minimal invasive surgery in low and middle income countries. We know that the situation is very bad. You have access to neurosurgical services within a 2-hour window in sub-Saharan Africa only in 25% of the areas, compared to 93% on Eastern Europe and Central Africa, and nearly 100% on Western Europe and the States. Knowing this, we also know that the people who work in lower middle income countries need to provide to their family. They do not have any free NHS or secure social service. They have to pay sometimes for treatment, money that they do not have in many occasions, and in that occasions they cannot have the operation done. And they have a large amount of infection rates during hospitalization, not only surgically infections, but also related to endemic diseases like malaria, cholera, etc. So what are the objectives in low and middle income countries? Well, create short stay in hospitals that will reduce infections and also reduce their complication rates. And we know that with minimally invasive surgery, these are two of the things that have been demonstrated clearly. Also, if you have become skilled with the procedure, you will have a shorter time during procedures that will reduce the infection, increase the number of the procedures you can do a day, and save more people from pain and other problems. You can provide training, and of course, the limitations are the current workforce situation, the referral strategies, you never know where the patients come from. Our technology there, we bring loops and headlights, but we rarely have microscopes and so on. I believe now things, and with the WFNS Foundation providing with instrumentation, headlights, and microscopes, this can be easily implemented. And then the experience and training. We go there, and when we go there to operate, we do not only operate, we also do some training courses so they can be used to the instrumentation. They have to understand the anatomy through a tube, which is different than the anatomy through an open procedure. And they have to understand the attitude, because there the learning curve plays a big role, because if you see that things don't work the way you want to work, they get depressed and they go back to what they know how to do, which I do not I understand fully. So we see many spinal cases, congenital malomyosile, and we see some deformities. But the one thing that we see and we have helped very much are in fractures and in degenerative disease. I remember a case in one of our first missions. One of these guys in these structures fall and sustain a big fracture. Fortunately, we had screws and we performed the fixation. He had a CSF leak, was a nasty fracture, but he could walk and everything. So the next day we go round to see the patients that we operated the day before, and we couldn't find this guy, and the guy has gone. So we asked the nurse, where is this patient? He's going back to work. I mean, you have to realize that they need the daily payment to feed their family. This is a big thing. So we saw the guy hurry up in the ladders again, working, and with the CSF pouring of the wound. And I said, we cannot allow this. We do the operations for a reason. And the reason is so they can survive and they can be back to work when everything is settled. One of the things that we introduced were these new equipments, which are all pre-sterilized. One of the big things or problems that we have found in these hospitals is the sterilization of the instrumentation. Sometimes shocking for us, as they dip the bipolar in some fluid and then they dry it, and then this is apparently well sterilized. So in order to improve on that, we brought all these equipments of pedicle screws pre-mounted, and from there on, we only use these equipments, and for that we are grateful to the two companies that provide us this for free when we go to these missions, and we take thousands of dollars in equipment so they can have it there. This is easy for the surgeon to learn. They're now using it themselves. The problem is, of course, the government don't pay these equipments, and they have to wait for us to bring them when we go back. This is how we put this. This is me on one side, our trainee from local guy from the other side, very much interested in using to put these pre-sterilized screws. And in degenerative disease, we see canal stenosis, we see herniated discs, cervical, lumbar, but we see also a lot of facet joint problems. They do not have a pain clinic there. And we were shocked one day that we had a list that had been cancelled because we found out that the patients could not pay for the procedure or the equipment that they require, blah, blah, blah. So to cut the story short, we found an empty list. So we said to other colleague, why don't we do some infiltrations to the people who come with back pain? So we did six patients that we had been putting on the list, on the waiting list to have a procedure. And after that, the next day was shocking to see a queue of about 20 to 30 people demanding the same operation that the previous guys had the day before. So that gave us an idea how much can you do and how grateful people can be back to work and removing the pain by simple and basic spinal, sorry, pain control procedures, facet joint injections. So to conclude, in the low middle income countries, the minimally invasive procedures preserve key stabilizing structures like the muscles that for these guys are very important because they want to go back to work. Not like here in Europe, we give them 6 weeks to 3 months to not go back to return work, but here they go next day if they can. Despite the lack of technology, they can benefit from some minimally invasive procedures. Percutaneous disposable material are a game changer for me in the traumatic spine. And vertebroplasty can be used easily for those who have osteoporotic fractures. Unfortunately, you do not see osteoporotic fractures that often in African countries, but I'm sure they do have them, but they just bed with them. The early return to work and less complications are also clue and crucial items to do these things in middle income countries. And this, for me, provides a game changer and a change of paradigm also, not only in Western world, but particularly in lower middle income countries where they have the same problems too. Thanks to all of this, I managed to see the late Pope and I explained our experiences back in Africa, and he happily helped us to provide some accommodation for trainee doctors to come to Barcelona so we could train them with hands-on experiences so they could send them back. And with COCEXA, we tried to organize something that we are still on the way to try and organize a program where they can benefit from coming to Spain and having some hands-on, not only observership preferences, but also hands-on. And why do we think hands-on are the key? Because we now do hands-on courses every year. Now we have expanded to Latin America and we do hands-on courses of minimally invasive surgery. They are courses of 2 days. We do them in Madrid every year in June, and we do it normally in March in Latin America, with the idea to expand to Asia maybe and to Africa if we have time and the strength, to be honest, because it's very heavy going to organize courses like this. The reason why we want to do these courses is because using simulation stations that we now provide, the doctors become confident, become knowledgeable, and they can use this on their patients easier. So what I've learned during minimally invasive surgery? Well, I learned to improve my skills through a small tube. It's amazing how can you manage yourself with a 16 or 18 millimeter tube and find these, remove hernias, go over the top, do an extensive laminectomy, tumors removal. You have learned this, and this is something that you must learn when you are familiar with the anatomy through the tube and that surrounds the tube that you cannot see. Taking the tube also to brain surgery. Now we know and we are knowledgeable now about procedures that have been performed in the ventricle through tubes or in areas to evacuate hematomas through small tubes, and these are also safe to preserve brain tissue. And understanding that minimally invasive is a viable option for treating multiple spine pathologies. We need to listen to the experts because sometimes you have problems and problems should not remove you from the final objective. And the final objective is do operations with less possible physiological damage to the patient. And therefore, this will all incorporate gains for the same patient, such as early return to work, early return to normal life, etc., etc. So to conclude again, minimally invasive reduce hospital stay, reduce muscle atrophy, and this is a very, very important. How many people do you know that you have done, or people have been done 4 or 5 operations openly in the spine? Every single operation that you do openly in the spine means that you kill a certain amount of muscle. Now, if you have 4 or 5 operations in the back, if you and the patient will have chronic pain, and this will be because there's no muscle left. There's only fibrosis, and the tension of the fibrosis alone will cause you pain. Measles also minimally invasive reduces the loss of blood and therefore infection. It is cost effective and it will become more cost effective as we improve our technology. And I am sure minimal invasive is here to stay. I used to play American football when I was at school, and as American football fan, I was moved by the words of Vince Lombardi, which was one of the creators of American football in the US. And he said, perfection is unreachable. But if we pursue perfection, we might obtain excellence. And I think minimal invasive surgery is about excellence. Just invite you, or these are the courses we are running this year in both in Madrid, Europe, and in Latin America, in Guadalajara. Abelino Parajon, myself from Spain, are organizing these courses. The Spanish course is 14 years old, and the American course is 3 years old. And we hope to expand as many places we can because we believe strongly that minimal invasive here is here to stay and it will improve the lives of many, many patients around the world. Thank you very much for listening, and I'm here to take any questions that may arise. Thank you again.
Thank you, Dr. LaFuente, for such an erudite presentation, such an amazing presentation, taking us through literally the history path and for MIS, giving us the advantages and the amazing work you do through MIS and even your mission in Africa. That's quite amazing. We sincerely appreciate that. We'll take questions if there are. There is a question on the chat. Jack asked this question, and I want you to take the question before the other attendee asks questions. The question he asks is, how many cases is required to gain competence with MIS for lumbar disc and stenosis? How many cases is required? You mentioned about steepness of the learning curve.
Yes, yes. Look, if you attend these hand-on courses, not only we do, but many other people do around the world, they use simulation stations. If you can do the procedure in simulation stations, now we are timing newcomers with a simulation station on how much time they take to do this procedure. If you can have the availability to use simulation station, the stepping curve reduces dramatically. Of course, it's not the same to do a simulation station than to do it in a real patient, of course. But it shouldn't take you, if you are familiar with the simulation station and you do 1 or 2 cases, it would be probably, I would say before, I would have think about 20 cases. With the simulation station practice, you may get down to 10 or 12 cases to become competent on that. You can start, of course, with a bigger tube, with a 22, 24 tube, and then you move down as soon as you regain the skill through the smaller tubes.
All right, thank you so much for that. Yeah, before Jack wants to say something, but before Jack says something, I want to just, as a rider to that question, for younger neurosurgeons who are aspiring to learn MIS, what will be your kind of candid advice on the nuances and skill set or mindset that such neurosurgeons will have? And how do you manage failure? Because I'm sure when you start these cases there were some failures, and so as a young neurosurgeon, how should someone manage failures, especially when he's trying to build such skill?
This is a very important question because you will have problems, definitely. You need to pursue. I mean, you will have CSF leaks, you will have damage of the nerve root, maybe, or infection, so on. But you will realize as you get better, this will disappear. And even if you have a CSF leak intraoperative, you will be able to sort it out without having fistula. Since I've been doing this for 15 years, I cannot remember when I had a fistula. I have had an accidental opening of the dura during the procedure, but you can manage this easily through a tube because the muscles come together and the CSF will never leak out afterwards. So you will give them 2 days to be flat and so on as a prevention, but it's a very good. Whereas if you open the whole spine and you have a CSF leak and you don't suture it well, it may leak through the wound because the tissues are open and so on. This is a very important thing. Never get depressed. You need to believe that this is the way forward, and it is indeed. I'm telling you, and then you have to find it by yourself. But this is the way forward to treat these patients. You will have problems, but don't go back. And another question I will tell you: if you are struggling through a hole and you cannot sort it out, and you're not happy, don't be scared. Convert it into open. We all have converted some of these cases into open, and this is for the good of the patient. It's not nothing to do with your ego and your how good you are. Forget about it. If you have any doubts, open the patient up a bit more and then sort it out. Eventually, this will stop happening.
Okay. Jack, you wanted to make a comment?
Well, I do. Yeah, please. Um, this is really a superb presentation. I mean, hearing somebody who really has the experience and has really gone through the learning curve, understands how to teach, it's really amazing to listen to because you can really depend on what you're hearing. Um, Interestingly enough, my residents are starting to teach me how to do this minimally invasive stuff. And you've touched on every question I've had and struggled with in the last, I guess, 2 years now. One question, though, is so you don't try to suture a leak. Let's say you get a leak and it's not some really large opening, but it's a small opening. I'd be putting in a suture in there is challenging. How do
It
you?
is very challenging. It is very challenging. I agree. I I can remember 2 or 3 times I that stitch because the opening was a bit bigger than expected. But if you have a small cutting, you put a bit of touch of seal or some stuff like that, you make sure before you go that you do Valsalva maneuvers and you will see that if it's a very small 2 or 3 millimeters, it will attach completely to the touch of seal or whatever fibrin glue stuff, and you will see that there's no leaking. And then on top of that, the muscle fall into it and it will not leak at all. I tell you, for the last 15 years, I have not a CSF leak in these procedures ever. I had damaged CSF, I have damaged the dura. I'm not going to tell you no. I've damaged the dura, but all of them, you are able to solve them there. And in 3 occasions, I converted to opening and stitch the suture and suture the dura because it was down in the root and you had no access through a tube to suture this incision in the sorry in the armpit of the nerve root. You know.
Okay.
Okay,
Dr. Alphen,
that that's
any other questions, Dr. Alphen, that people are asking?
well, no question on the chat, but I have this thought to or question kind of to ask Dr. LaFuente with respect to LMICs. I practice in Nigeria, which is a lower middle income country. One of the major challenge we have is equipment. When I looked at your OR, I could see the array of, you know, intraoperative CM, the images, the equipment. You know, for me, I can only dream of that and pray that someday I will find access to this equipment. So for someone like me who has interest in MIS, fine, how do I start? What do I need to do? Looking at where I am, what will be your advice?
Yes, this is a question that always comes back, and I say, oh, you are very lucky you have this, but you have to remember that for me to obtain this, it's taken me years of fighting, making things understand to the officers of the hospital, to the managers. They have to spend a lot of money. So first of all, you need to believe this is the way forward. If you believe this is the way forward, a microscope you need to have or big loops. You can start with microdiscectomies, with over-the-top laminectomies through a tubular system. Tubular systems are not very expensive, and they can be obtained maybe through WFNS Foundation. Other NGOs can provide you some basic equipment. You need only tubes and imaging intensification. Okay, you don't need the CT scan interpretive, the robots or anything like that for studying. And of course, to put lateral cages or olives or anterior cages, you do not need an even microscope. And these are also minimally invasive procedures because you don't cut muscle really. You just separated the muscles and you go through normal inner muscle planes. That is what, for me, what a definition is of minimal invasive, is protecting the muscle as much as you can. And you can do most of that stuff, but you need the cages. The problem that you don't have is not imaging, but the A-leaf cages, the lateral cages, are all these very difficult to obtain in your countries. I do not, I have been able to bring these screws that I show you in the presentation. I've been able to bring endoscopies. I have been able to bring this, but I could not bring A-lifts, olives, and lateral lifts, not even T-lifts to Kenya or to Tanzania, which is where I've been working most of the time.
Thank you so much. Last questions before I drop off to Jane. This is a question from Sekaluya from Koseksa. He's a resident in Koseksa. He's asking this question: what are the requirements he needs to be able to attend the hands-on course in Spain, being a Koseksa resident in neurosurgery? So, what requirements?
Yes, the hands-on courses that we run in Spain, these are available to anyone. I mean, but I'm sure he's referring to the project that I had with the Pope, referring so they could come as a resident with hands-on preferences. So they don't come there only to observe. They come there and they operate with us, with the consultants there. This is very difficult to obtain in Spain because Spain has a system like in the US only for residents, trainees from the US or Spain. Now we are trying to force the arm with a pilot study. So 3 or 4 people, and we talked to COSEXA trainees first because we were vinculated through Kenya with them. And we spoke to them that if we obtain the permits from the National Health Service of Spain, then we will be able to allow to do this. And if we get this, we will have to speak to COSEXA, and we are planning to bring year 3 residents to spend 1 year with us. But this is still difficult to obtain because we are planning to give them the same rights as a normal resident, and this is difficult to get it through, politically.
Thank you, Dr. Jesús LaFuente. And Jack and Jane, I think there's no further question. We hand over to you. You have any comments or further announcement? Thank you.
Just one maybe last comment. I mean, it was a really, really inspiring presentation. You're really an excellent speaker. Your experience shines through on all you're talking about. And I think the audience really, really can benefit from that. So we thank you very much for sharing your Saturday afternoon with us. And I'm sure that Dr. Dempsey is going to be proud to be associated with this presentation.
Thank you very much, Jack, for your kind words. And Dean, I have to tell you one thing. I am here in my summer house, and a friend invited me with the boat this morning. Now here is 5 o'clock p.m. and we were in the boat, and the boat broke. So we had to find the rescue to come and pick us up. So I was here 15 minutes before the talk had to be started. So I was very lucky to start. Thank you for your kind words, Jack and Dr. Alfin Dumura and Jean, and pleased to be here and great to be part of
Thank
the
you so much.
project. It is amazing
Yes.
what you also do there. Thank you,
Thank
guys.
you. Thank you very much,
All
Dr.
right.
LaFuente, for your time today and for your incredible presentation. As Jack said, it was superb, really, truly. And thank you very much, Dr. Alfin, for taking the time and being here to present and or to introduce Dr. LaFuente. And thank you, Jack, for finding Dr. LaFuente, finding this expert in this field. And really, truly, what a gift for you to be here to share with all those that were able to attend. And thank you to the board members of FIENS that are attending, Dr. Young, Dr. Mosier, Dr. Johnson, and Dr. Rock, the other Dr. Rock, who also was attending. So thank you all for coming and listening. And this recording there's many people who signed up and may not be able to attend right now, but will be watching the video later. So it will be available on the FIENS website under Virtual Visiting Professor within probably a week's time. And Dr. LaFuente, we can share a little bit more about your workshops that are coming up, through the FIENS channels, because we definitely want to support you. And we just thank you very much again for being here.
Thank you. Thank you for your kind words. Thank you all.
And we're glad you're safe
See you
too. We're
soon.
glad you made it back.
Thank you. Bye-bye.
Bye-bye.
All right.
Bye.
Bye-bye.
Bye-bye. Bye-bye.